to quality-centered care around individuals, carers, and communities' needs. It prioritizes the individual's participation in their own care and emphasizes the importance of a supportive environment for carers. This is a shift away from health systems designed around diseases and health institutions to those that are designed for people. And to operationalize PCC, we need to make changes in 3 areas. First, our policies and the way we finance care. Secondly, we need to look at the way we develop our workforce and hold systems accountable. And thirdly, we need to look at the way we design and deliver services. We've designed our 3-part series around these 3 main areas of change. But today, we're going to be focusing on what it takes to govern and finance person-centered care. Financing and governance for person-centered care is very complicated and could be sensitive, but it's really essential to creating an enabling environment that would allow us to deliver quality person-centered care. I am joined by a distinguished panel of experts who represent a diverse group of actors working to make person-centered care a reality around the world. We have a representative from a ministry, a global governing body, as well as 2 implementers who have experience delivering PCC programs. I'll let each of them introduce themselves to you now. Andy, why don't you start us off?
Thank you so much, Kate. It's a real pleasure to be with you all today. My name is Andy Seale. I work at the World Health Organization at the headquarters in Switzerland. And I work in the Department of Global HIV Programs, viral hepatitis, and sexually transmitted infections. So my work involves developing some of the strategic frameworks that help guide the kinds of work that we'll be exploring today, and also working in partnership with a number of institutions also active in this field, including, most importantly, communities. Thanks, Kate.
Thank you, Andy. Phillip?
Thank you very much, Kate, and welcome to the rest of the people who have joined us on this webinar. My name is Phillip Kamutenga, and I work with JSI. And my sole focus really with the work that we do is to help national governments build robust supply chain systems that ensure that there is an uninterrupted supply of medicines and medical supplies. The thing to note, which is going to be critical in some of the submissions I'll make, is that in most of these countries, they're really resource-constrained environments. In other words, the finance is always a challenge. You do not have enough resources. So everything that we have to do has to have that as in the background. But that's the background, and that's what I do day to day. Thanks, Kate.
That's wonderful. We can't wait to hear from you later, Phillip. Senta?
Thank you, Kate, and JSI team for having me as a panelist today. Welcome, participants. My name is Sentayehu Tsegaye. I am working as Deputy Country Director here in Amref-Ethiopia, Ethiopia country office. I'm also serving as a Chief of Party to one of USAID maternal child health program working in developing regional states, predominantly pastoralist areas. As you know, Amref is an African-born, African-based organization working in more than 35 countries, mainly at the community level up to the national Ministry of Health and other sectors as well. Welcome all. Thank you.
Thank you, Senta. Lloyd, can you hear us? We seem to be having a little wonderful. Great.
Thank you. I'm Lloyd Mulenga. I'm the director for the National AIDS Council in Zambia and also the director of infectious disease for the Ministry of Health. I've been largely involved in HIV service delivery models and also implementing some of the policy issues which affect the whole infectious disease system delivery from the standpoint of government. Thank you.
Thank you, Lloyd. Thank you so very much for making the time for this important topic, everyone. I'd like to get started by talking about creating an enabling environment that supports person-centered care. Lloyd, from your vantage point leading the infectious diseases branch of the Ministry of Health in Zambia, how do we create an enabling environment to support person-centered care?
So to support person-centered care, we need to, first of all, shift our mindset in terms of what it takes for delivery of the health systems. We always do programming according to disease entities, and we always do also programming according to the budget funds which are allocated to certain entities. Now, what we need to do is we need to have involvement of the community. We need to involve the people that we do serve, and that when it comes to the policy change, we need to have wide consultative engagement from the community to the health facilities to look at health workforce, then also to encompass all those aspects which do take into delivery of person-centered care as we go up now into the budget preparations. Then from there, you now go into policy aspects. So we really need a change in the way that we think, especially as policymakers, and we need wide engagement of the community for us to move forward in person-centered care service delivery.
Thank you so much. That's really important. You talk about really involving the community and shifting our mindset, having that early engagement of colleagues before even thinking about the policy. So you can, it's almost like a bottom-up approach. That's wonderful. Thank you. Andy, what about WHO? What's WHO's role in creating an enabling environment for PCC?
Thanks, Kate. So first of all, we have country offices in 149 countries, including Zambia, of course. We really value the relationships we have with our Ministry of Health and other health stakeholder colleagues in countries. And I think it's really important that we're always listening to and getting feedback when we're working in headquarters from countries. And I think there are two things that really help us out with moving this agenda. One is establishing the right strategic frameworks that actually create the policy connections. And then the second one is building on those connections to make sure that teams and individuals who work in health are connecting and working across, perhaps taking themselves out of their comfort zones sometimes, so that we're connecting the HIV people, for example, with the people who are working on primary health care, and really looking for synergies, because we always find commonalities when we do this work. So the critical thing really is to create the policy frameworks and the tools that can support those conversations, and then really facilitate that cross-connectivity across the health system. And I would also agree with Lloyd that bringing communities in to keep us real is really important, whether you're working at headquarters, regional office, or in country.
Yes, we must get out of our comfort zones to get this done and think about other ways that we can work with other people, perhaps, that we haven't worked with before. Phil, let's look at supply chain. You already talked about it in your introduction. You work with people, from the top to the bottom of the health system. What are your thoughts? How do we create an enabling environment in some of these resource-constrained settings that you talk about?
Yes, the reason I prefaced my introduction with the idea of the resources being one of the key drivers in this work, it means that if we do not have enough resources, then we need to prioritize. Whatever interventions we're going to implement to support the person-centered care will require that we prioritize because we have limited resources. But then how do we determine what we need to prioritize in the context of supply chain or broadly public health? I actually came up with three elements that I feel can be helpful. Some of this has already been touched on by Lloyd and Andy, but I will just quickly run through that. So the first part is personalization. So this is where the mind shift, we need to shift our minds, comes in. So I'm saying personalization because we're trying to go as much as possible to the individual. It's easier when we're up the chain to make decisions on behalf of the people lower, as you go down. The idea is that you want to be as much as possible to capture the individual, the family, the community, the staff at the health facilities, going up to the administrators and eventually the policymakers. They all need to be listened to. We need to ask questions. So this is the space where we talk of, emotional intelligence and psychological safety type elements, because you need to give them room and the comfort and the ability to be able to speak and say what they feel. So once we have captured all that information, let's call it data and evidence for now, then we can now use that to create specific interventions that actually speak to that feedback, and then also speak to the resources we have, so that we can target the 20% that informs the 80% of our outputs. And that is that understanding that we have to start with the people so that we can design the supply chain that is mature enough and can actually provide what I talked about, uninterrupted supply of medicines and medical supplies. It will require for us to go through that process. It's not easy, but it's the only way for us to get to person-centered care.
Thank you so much. That's really wonderful how you sort of taking us through that whole process of prioritization. We'll probably come back to that a little bit more. But let me pivot a little to sort of the center. You're one of the largest NGOs, you've said it in your introduction. And again, in the context of what we've said, Phil just linked us to one of the most important things is the resource constraints and how you prioritize. How does Amref approach the delivery of person-centered care?
Thank you. I think I would like to kind of highlight three important considerations that Amref usually do when in terms of coming into policy formulation, making sure that the financial environment is focusing around people. So one is intentionality of evidence synthesis, evidence generation on the person-centered care. So as you know, the person-centered care, usually the tendency around the medical health service aspect is very critical, but equally important is the non-medical aspect. How the service is provided and affect individual preferences. People have their different way of engaging their service into a different system, but in any circumstances, they want to ensure their dignity is respected. They want to get a coordinated type of services as much as possible. So in our evidence generation, we kind of tend to focus, okay, what are the non-medical aspects that we need to factor in? So the least that we can do is the do not harm principle. So if I cite an example, a person may come to a health facility for a certain disease, but that person should not be, carry another illness because he appears in that facilities. So the safety of the patient. So what policy implication we have in terms of keeping the patient safe? So the patient flow, the infrastructure that we are putting in place, the commodities or the supplies that Phil just talked about, all parameters, they have an implication on, people's experience, getting care. So how is our evidence shaping that policy is very critical, because any policy has an evidence generation or evidence synthesis component. That's one. Secondly, engaging stakeholders. When policies are drafted or formulated, we need to make sure that all stakeholders need to be engaged, especially how are we engaging the people themselves. People, when you are talking about community, it is a fluid. It's a very diverse understanding. So how can we systematically engage the communities? So civil society organization, how can we ensure the youth engagement? Amref has a youth development agenda. We have a youth programs. How can we make the majority of the people, the youth, are also heard? Women are the majority. However, the voice of the women are also heard. So stakeholders engagement are very critical, and how people are also considered, being considered is very critical. Equally important is also service providers. healthcare providers, their voices have to also be heard. We know that there is a tendency for 100% client satisfaction tendency, but we need to also make sure that how is the provider satisfaction in terms of providing care. So I think, Kate, you have mentioned that human, development or human workforce is another pillar, but in policy formulation, they are also the major stakeholders. So Amref also working with different professional associations to make sure that the voices are heard. But at the end of the day, policies have, resource implication. So at the end of the day, if you talk about universal health coverage, one parameter is out of pocket. To what extent is services is catastrophic for the economy of individual and households? So how is our prioritization to minimize that cost? How is our coordination to provide a kind of one-stop service so that the cost, especially to the people, are minimized as much as possible? Over. Thank you.
That's really great. I like how, it's almost as if it's a choreograph between our panelists, Senta, you're getting us to some of the real elements that we think about when you think about the person, which everyone has talked about, the dignity aspect of it, the do no harm aspect of it, some of those non-medical elements that really encapsulate person-centered care. And while Phil talks about the prioritization and the funding, we also then, you bring it down to what does it mean for the individual? Does it make them poorer? Does it increase poverty? And is that a harm that is done to the person? So thank you very much for that. Now we're going to pivot a little bit. We're beginning to see how really complex this is. We want to talk to each person. We want to understand their needs. At the same time, we have funding constraints that we have to think about and prioritize. So we do have a question from Mina, our colleague in the Dominican Republic, around funding streams for delivering person-centered care.
Hello, I'm Nina Halpern-Losada, and I'm the Executive Director of Clínica de Familia La Romana, an NGO based in the Eastern Dominican Republic. We provide person-centered, comprehensive care and treatment to over 2,500 clients with HIV at our community clinic, as well as health and education services to other vulnerable populations. My question for today's distinguished panel is, how can we promote, plan, and deliver person-centered care at clinics like ours, Clínica de Familia, that are highly dependent on external donors and siloed funding streams? Thank you very much.
Thank you, Mina. So let's start with you, Andy. How do you think we can overcome some of these challenges related to siloed funding streams?
Thanks, and thanks again for the great question from Dominican Republic. I think fortunately, some of the biggest donors in this space, so for example, PEPFAR and the Global Fund, they've already been anticipating and planning and supporting this evolution, if you will. I mean, it's quite clear that we needed public health approaches to get huge amounts of treatment out to as many people as possible in an emergency model some years ago, which is why WHO had the treat all policy, for example. But we work closely with PEPFAR, we work closely with the Global Fund, and we know that it's that it's high time that we continue to evolve a person-centered care approach through things like differentiated service delivery. So we're not treating all people living with HIV exactly the same. Some people will be classified as stable patients, will only require clinic contact every 6 months. Others will require much more frequent contact. We know from communities that they would like choice when it comes to ARVs, for example, and some countries are in a position to be able to provide that. So I think all of the issues that have been raised around resources are absolutely critical. So I do think that the optimal ideal would be linked to optimal choice for each individual, but that's not our reality actually in all countries of the world. But particularly the countries like Dominican Republic that do have funding relationships with organizations like PEPFAR and Global Fund, I think it's critical that, again, back to my first point, connecting the right teams and people. So for a long time, particularly since that Millennium Development Goal to Sustainable Development Goal transition, there's been a much stronger focus and expectation that we do more around that connectivity around systems. We talk more about sustainability. We're smarter in our investments. So we think short-term, medium-term, and long-term. And in doing that thinking, we're bringing in the people from across health to really be part of that conversation, to connect the various parts of the systems. And of course, health systems are multiple systems. So you've got your budgeting and finance system, testing, diagnostics, and systems, etc. There are multiple systems that come together, and it is complex. But it's really mapping out your local system, identifying the key champions that can unlock some of the solutions around that connectivity piece, and really just make sure that we're building those connections in, whether it's making sure that strategic information systems speak to each other, or budgeting and accountability frameworks are speaking to each other. And I guess the final comment I'd make is that, again, mutual accountability frameworks that allow for communities, and it was great to hear health workforce mentioned before. Of course, they're a critical stakeholder in this, so that we hear from the workforce, we hear from the communities, and we include policymakers and managers in that conversation. So this is where you facilitate levels of accountability that allow for different perspectives to be aired and to contribute to the management. We're going to be in a stronger position to move this agenda forward. Thanks.
Thank you, Andy. You continue to bring us into this whole idea of the ecosystem, right, that we're talking about. And every one of us is, thinking about the ecosystem for the service delivery and the ecosystem for the funding. And we need to know what that is and then connect all the right people. And I like that you talk about accountability being mutual. It's not just, on the health providers, but there's also accountability on the community and on the people as well. So thank you so very much for that. Lloyd, we know that Zambia has multiple funding sources from different donors, from different health areas, but you're still able to provide holistic primary healthcare services. Tell us how you've been able to make this work in Zambia.
Yeah, thank you. I would say that really it starts with what you want to deliver, but also the voices to be of the community. They do matter a lot. They guide us. We have been able to provide primary healthcare services. I would say possibly a lot of support has come from government, but we also have some funding sources. PEPFAR has been one of a great supporter and also donor to this country, and the ministry in particular. We have the Global Fund, we have the European Union as well. But what we try to do is to create a package which all these funders are going to buy in. And for you to create such a package, it has to start with engaging with, as I said earlier, and repeated by the panelists, community very key. But also our systems, they depend highly on the policy issues which are coming from the ministry. And we have created that environment together with engagement of the community action. And all these donors, they come in and buy into that. But I also need to mention what Andy also referred to, the fact that we need to also go into domestic financing centered around this approach. Even as countries are moving more into sustainability for HIV care services, we don't just need to think of HIV alone. We need to think that our people, they have hypertension, our people, they have diabetes, our people, they have cancers as well. So when they come to the facility, let them find a system which is responsive to all their needs. And that has to start with the policy shift, which we do make, and deliberately make resources available. Thank you.
Thank you. Thank you. I like how you highlight the power of governments. In spite of multiple draws from funders, the governments of our countries can still be able to determine how these funders actually work with them to support the needs of their people. That's really helpful. So leadership in the country is critical, as well as also not just in harnessing donor funding, but also in generating domestic financing. That's really wonderful. Senta, is there anything you'd like to add here?
Yeah, thank you. I think promoting the plan and delivery is a very critical aspect, but I would say that the person-centered care can best be promoted through enhancing the primary health care approach by integrating the health system inputs or investments. One approach could be finding the best diagonal approach that balance the different public health functions. You know that there is a vertical public health function, which is health promotion, disease prevention, curative, palliative, rehabilitative services. These are the vertical public health functions, which directly touch individuals, families, and so on. And there is also a horizontal public health functions, which is availing essential inputs, human resource, supplies, finance, and so on. So what is the best, diagonal approach that can put the people or the person at the best, position to benefit from the services? So with that tone, people may defer my, calming opinion. We should strongly discourage vertical programs with no health system component. So Andy was mentioning that PEPFAR is doing health systems. Global Fund is for HIV, TB, malaria, but they do health systems. Gavi is for immunization, but they do health systems. So they are trying to bring the different, health promotion, disease prevention, curative services of HIV, TB, malaria, and so on, with that of the horizontal approach. So silo approach of verticality will kill the health system, which is the base of. So that's one component we need to address, because people are affected by disease at the same time, by different diseases. But if not at the same time, in the course of life, they will get, another problem in the way. So the system needs to get prepared to serve the people in the course of their lives. That's about universal health coverage. The other thing is we need to also make sure that we buy into the host government's plan, strategies, alignment with their priorities, aligning, harmonizing our major activities are very critical. This has been there with the aid effectiveness since 2005, but living in a true sense, it makes a lot of, difference for people or person-centered approach. For example, the question that came from Dominican Republic around, HIV program. In HIV, for example, in PEPFAR, there is what we call a differentiated service delivery model. So the differentiated service delivery model, it could be a model led by the clients themselves. It could be a model led by the health care workers. It could be appointment spacing and so on. We are bringing options to the people so that they can pick their preferred model, but when they pick, they can also shift from one model to another model. There should be that flexibility. But in order to avail that, the health system needs to be ready. You have the human resource, you have the commodity to go to the community. Should you keep the commodity at the health facilities are critical elements. So when you plan with the government-led owned planning and help them to avail different options for the service delivery models, that will make a difference. So that approach of a diagonal-based approach might serve the person-centered design moving forward. Thank you.
Yes, the health system must be ready to deliver person-centered care.
Yes.
However, we have to discourage vertical health programs that have no system strengthening perspective. Thank you so much, Senta. So we now understand that vertical programming doesn't work, but even the funding can be quite complex to navigate. And we've seen, some of the examples and suggestions from our colleagues in how to navigate those and how leadership is critical to making all this work. So now I'd like to turn our attention to behaviors and characteristics that our leaders and managers need to exhibit to effectively implement person-centered care. With that, I'd like to draw attention to a question from our colleague, Dr. Charlotte Colvin from USAID.
Good morning, good afternoon, and good evening. My name is Charlotte Colvin. I'm a senior technical advisor with the tuberculosis team in the Office of Infectious Disease at USAID in the Global Health Bureau, and I'm really happy today to be part of this esteemed panel and session. I spend most of my time working on pediatric TB, a population for which patient-centered care is critically important. And the needs of children in terms of patient-centered care are often quite different than the needs of adults. We often find that providing patient-centered care to children requires taking risks. It requires doing things differently. And I'd love to hear what our distinguished colleagues have to say about how we adapt management styles, training styles, how we can encourage some risk-taking, how we can encourage some changes in practice when we're really focusing on patients and populations that really, really require patient-centered care, but perhaps in a very different way than we've thought of before. I appreciate any insights our colleagues have, and thank you so much.
Thank you. So Phil, I know you're an executive management coach as well. So wearing that hat, how can we incentivize risk-taking and flexibility in public health leaders?
Yeah, no, thank you very much. And that's a very valid question, especially when it comes to children, because it's very easy for us to, make assumption they're children, they don't get it. Of course, depending on the age here when we talk pediatrics. But let me, say one small thing about the science, the behavioral science component here, that for people to change, we all want change, right? We just talked about change of mindset. But we also know from science that for people to actually change, they have to want to change. That's number one. And number two, generally speaking, people do not like big bang change, right? Usually if it's evolutionary, it comes slowly. This is why when we look at 10 years ago, we say, geez, things have changed, but you actually didn't notice the change. So I wanted to put that as a background to my submission here, that at the end of the day, for us as leaders, for us as service providers, whether we're working with children or with adults, the fundamental issue is to try to listen to them. So I usually work with three elements when it comes to any coaching, any work that I've done with executives. It starts from the place where you need to ask questions, right? More questions and less advice. More questions and less advice. The idea is that when you ask someone a question to hear their opinion, whether it makes sense or not, it shows respect. Immediately they're interested in what you're asking. So they are part of the process. So asking more questions will help. And then obviously by default, you have to listen. You have to listen to hear exactly what they're saying. It's very easy for us to go with preconceived ideas, but we have to listen to what they have to say and listen deeply. And part of listening is to validate what they are saying. The third part is follow-up. So we can visit a health facility and speak to them, or we can visit a pediatric section where if there's children who can understand a few things, we can talk to them, ask them. I've seen a pediatric speak to my daughter, and it's amazing when they do it really well, to a point where the children want them to, look into their eyes and their nose and their mouths and all that. It goes back to that connection. So we need to connect to the people, and then we have to follow up to check in, to track whether or not that which we discussed and agreed to execute or implement is actually working. That it all comes down to that, asking questions, listening, and following up, so that which we try to do is actually working. So I can go in and say, is it working? If it's not working, what do you think we could do? So that's the baseline for any work that we do, whether you're talking to a child or you're talking to an adult. And that fits into a lot of other things in terms of leadership, but that's a starting point. I can share more if needed.
Thank you. And I'll go to you, Senta. Ethiopia is one of the first countries to call out PCC as a strategic objective in their national quality strategy. So do you have some examples to share about how leaders and managers take on and implement PCC in Ethiopia?
Thank you again. I think this is a nice question. I think I would say that, if the right evidence is there, leaders are usually keen to take actions forward. So in case of the Ethiopian Ministry of Health, there was a lot of effort around quality during the health sector, development plan in earlier days, and then later on the health sector transformation plan. So as an expression of, focus on quality, the Ministry of Health has set up a quality directorate. And then across the board, down to the public health system, to the regions, to the facility, the quality team started to be established. So the Lancet, finding, I think back in some years ago, that if you have a service with no quality, it's better not to count it, because a sizable portion of people are, dying because of lack of quality. So that really resonates into the leadership of Ministry of Health, moved them into establishing a directorate, and then that moved to, cascade down into the other aspect. Then there is also another element when it comes to person-centered design. Ministry of Health here in Ethiopia is also very vocal in terms of advocating for multi-sectoral collaboration. So the idea is that influencing, not only public health leaders, but also other leaders requires beyond advocacy, beyond generating evidence, to move our agenda forward in terms of person or people-centered design. It requires courage, it requires guts to move away from our comfort zone of data mining within the health sector, advocating within the health sector. Sometimes we are preaching the choir, we are preaching each other. But what we need is also other sectors. Health sector is not viable without other sectors. So that should be truly understood by the public health leaders, so that they should move out from their offices and go to other sectors, make sure that social determinants of health are addressed. Because for people, health might not be their #1 priority when it comes to the true life. It could be economic, it could be peace, it could be whatever. So we need to make sure that health has the right position in the development arena, so that it is a means for development. We need to show them the return on investment. We shouldn't just capitalize on that. Health is a soft target for everyone. When you talk about health, everybody has a soft heart, but health is beyond that. It has a return on investment. We need to capitalize on that. And again, health is also a product of development. If a nation is claiming that it's moving from low-income country into a middle-income country, the development of the health sector should also commensurate into that. We know that there are African countries with a middle-income status, but a health status of low-income, status. So if we are bold enough to work with other, sectors, to work within other sectors, we can get the soul and the heart of leaders, not only the public health leaders, but also other leaders, so that they can play their role better, so that the health sector will benefit. Ultimately, that will benefit people, that will benefit individuals. If the road authority builds road better, at the end of the day, the laboring mother will have a better access to go to health facilities. If there is clean water by the Ministry of Water or whatever, that poor child suffering from diarrhea will get a better, potable water. So health will benefit from that. Individuals will benefit from that. So in order to incentivize leaders to take risk, to be flexible, we shouldn't keep ourselves within the health sector. Let's go out and work with others, because at the end of the day, health benefits the sector, but individuals will benefit. Thank you.
Thank you. Thank you, Senta. We have just a few 15 minutes. So we'll get to the last question from Dr. Anamo Motisi from Zimbabwe. And she's going to ask us a question around stakeholders in delivering PCC. Dr. Anna Moore.
Hey to you all. My name is Dr. Anna Mutisi. I am a technical advisor with the Zimbabwe Association of Church-Related Hospitals, which is known as ZACH for short. Our organization works with mission hospitals and clinics across Zimbabwe, and we are implementing a number of projects, including our HIV care and treatment project, voluntary medical male circumcision project. We've got 3 COVID-19 vaccination projects, as well as a gender-based violence project named SASA. So patient-centered care for us in all of our projects really just doesn't look at addressing the clinical needs that our patients have, but also trying to achieve the desirable outcomes by looking at the emotional, the financial, the social needs that our patients also have, and really involving them as a stakeholder in their own health, and giving them the literacy that they need to be able to make good decisions towards their own health. So my question for you, dear panel, today is what role can civil groups and advocacy groups play in helping lead and financing patient-centered care? Thank you.
Thank you, Dr. Mutisi, right there. And I'll start with you again. We don't have a lot of time, so real nice and sweet and short responses. Center, Amref is now the current host for Gavi's Civil Society Forum. So what are your thoughts on this question from Anna Moore?
Thank you for the question, Anna. So what I would say is CSOs should remain loyal to their constituencies. So when they represent, their constituencies, there should be a genuine and, a depth consultation dialogue with their members, and there with the local, service providers, so that issues of accountability are addressed. So some of the challenges we are observing as, this role, some, CSOs, their quality of consultation with their constituencies, is kind of questionable. So we need to have a mechanism, a way, there should be a true reflection of what the voice of the people are there. So it could be professional association, it could be patient associations. It shouldn't be few people leading that CSO coming to the platform and take the assumption that this is what's happening behind their fellow membership. So that is the most important element. And the other thing that our advocacy elements should corner and should put the people first. So what can we make sure that the 4 principles that we are focusing on, person-centered care, how people can get a service that has dignity, compassion, and also respect. What are the parameters? If that's not the case, how can we challenge that and correct timely? And then they need to also advocate for a coordinated, concerted effort. People should not spend their time here and there because the system is disorganized. And the other important element is empowering of the individuals. We need to find out what are the strengths, the capabilities of the community. There is immense community wisdom, in the community. How can civic society organization tap that and bring onto, programs, strategies, influence policies are very critical. And the other element is that governments alone cannot deliver services enough or adequately. Communities themselves, civic society organization, private sector have role to play, that role. So how can we mobilize more resources? How can we bring the community all together? It may not be necessarily in monetary terms, but the time, the labor, the skill is within the community. How can we coordinate? Can they serve as a convergence point so they can transparently and also, in a respectful manner, deliver what's happening, what available resources on the ground to the people they are standing for. So I think if that momentum of civil society organization improves and be loyal to their cause, the person-centered approach will move further than now.
Thank you. Thank you so much. Lloyd, do you have any thoughts on this question?
Sure. And I think I would like to take this other perspective of civil society being a great partner to government. But also there are other stakeholders. We have, I'll give an example of CQUEEN, which is funded, I think, through the Bill and Melinda Gates Foundation, where they have championed really the differentiated service delivery. They bring governments with CSOs together, and in one room you start discussing one topic and championing one topic. Or in this case, I think person-centered care can be championed through that means. I think we need to have also this high-level engagement and deliberate engagements where governments, CSOs, and other stakeholders come together championing person-centered care. Thank you.
Thank you so much. Andy?
Wow. First of all, I fully agree with Senta and Lloyd with those inputs. I think conceptual clarity is really important around how we look at that landscape of stakeholders. So, for example, building on Senta's point, there is a difference between international NGOs and community groups, and they all have a role to play, and they should be mutually supportive. We need to apply a bit of a power analysis to who's in the room or who are the stakeholders, and make sure that we are really prioritizing hearing from affected communities. And linked to that, and some of the previous conversations, I think there is also the question of data. We know that people and policymakers react to data. So we have a responsibility to work with communities to identify gaps and to fill those gaps. So if there are gaps around pediatric or adolescent care for TB or for HIV, reaching kids with HIV medication is harder than reaching adults. We have the data, and so we're responding appropriately, working with communities. So I think, having that conversation, having conceptual clarity, first of all, around the stakeholders, and then working collectively around the data gaps and what data exists with a deliberate focus on reaching the unreached. I think that's critical. And perhaps I'll stop there. One final point. I think language and framing in this whole conversation is really, really important. And personally, I've worked in this field for more than 20 years now, and I struggle to see these days an HIV vertical program. I actually think that most HIV programming is linked, certainly around comorbidities and increasingly across a systems approach. And we're just seeing more and more of that. So I think if we can build and win-win language, I think the days of having a vertical versus horizontal paradigm, perhaps they're behind us to some degree. So I think as several of the speakers have said, most HIV programs, for example, are really built on a disease focus plus a systems focus. And I think we need to emphasize that, that interface and encourage more of that moving forward, but prioritize communities. Thanks.
We don't have a lot of time left, so we've seen some of the questions that are in the panel. We'll have our panelists respond to them because we'll ultimately have a summary to share at the end. But I just want to take the remaining time that we have to just ask our panelists to give us one minute response in terms of final thoughts. And I'll start with Phil.
Yes, I think we are tying to the CSOs, but I think broadly for all public health, we need to realize and leverage the power that the community has. In fact, if you tap into communities and community leaders in particular, right? But community leaders have got the ear of the communities as you go to the lowest levels. So that power dynamic, if a CSO or any unit within the public health system can tap into the leadership, and then it's the fastest way, if not the easiest way, to actually get to the community, because they're usually the gatekeepers. This is reality, right? So when we work with them, leaders themselves, community, do struggle as well in dealing with their own people. We can also help them with these behavioral elements that we know and psychological safety elements, where they can also accept a certain level of dissent, accept mistakes, but also make sure people learn from those mistakes. And also the idea of, asking questions and the rest of such, so that you can get as much input from the lowest level, and you can use that as a way to lobby and advocate upwards, so that also the leadership don't sit there comfortably and not realize there is actually power. So that balancing that off, I think we can get to a place where there is alignment between the lowest levels and those at the high levels.
Lloyd? Final thoughts, 1 minute.
Yeah, indeed, my final thoughts is that engagement needs to start now, and it needs to move from the community all the way up to the policymakers. We need to utilize the environment which we have right now in various countries and various governments to engage them. Thank you.
Thank you, Lloyd. Senta?
Thank you, Kate. What I would say, maybe I'm repeating myself, the person-centered care can be well addressed if we truly capitalized on our primary health care approach, which encourages contextualization. If we truly contextualize to the people need and apply the primary health care approach, it brings primary health care predominantly health sector led. It's about empowering individuals, their families, and communities. And then most importantly, we are having current health status. We are having this behavior because of other socio-economic determinants. Primary health care is the way forward to progressively realize UHC so that we leave no one behind. Thank you.
Thank you, Senta. Andy, one last thought.
Thanks. Well, I think this webinar has really set the tone for what I'd like to say in conclusion, and that's really just be open to listening, open to learning. I think, public health practitioners, health workforce, we're all constantly learning. And if we stopped with that curiosity, we should try and find ways to become curious again. We're constantly learning from each other. So be open to hearing from colleagues from different parts of the health system. There's a lot for us all to learn. And I think recognize as well that health literacy within communities is different today than it was pre-COVID. So actually we've got a situation where we've got an increased kind of like baseline really to work from. Things have changed since COVID, but some of that change has been very positive. So the conclusion really from my side is really just be open to learning and apply the learning.
Thank you all for these comments and for participating in this very wonderful event. We appreciate your sharing your thoughts with us and your experiences. But before we leave, I'd like to highlight a few takeaways that we've had from this conversation. First, it's critical that people who lead policy, leadership, and financing decisions engage the individuals that receive care, the communities, the health providers, and as part of the decision-making processes. Our panelists have described to us how we can create policies that break down funding silos. In fact, how, even funding silos funding silos that we currently have are already integrating health system strengthening elements that indicate some breakdown in those silos. They've worked with leaders to think outside the box to implement person-centered care. We need to be curious, as Andy said. We need to find ways to engage and connect with people, as Phil said. And finally, they've also looked at the way that civil society can be an active partner in implementing PCC. So it's a connection with everyone that is involved in this ecosystem of person-centered care. I like how Lloyd talked about the partnership with civil society and government. That's what we all want. And Andy talks about the whole compartment, the whole package of INGOs, NGOs, civil society, government, and of course, the recipients and providers of care. Lastly, we need to hold people with decision-making power accountable to ensure that funding is available at the right time. And whatever funding is available, that they have the right priorities. And those priorities need to come from the people. So that we all hold one another accountable. I like that the panel has mentioned that accountability is not a one-sided game. There's a mutuality to accountability that we must all acknowledge and hold one another to, so that we can really deliver quality person-centered care to our communities and our people. So thank you again to our audience. Thank you for the audience questions. There's quite some participation in there we can see already, and our wonderful panelists for such an informative discussion. We've recorded this session and we'll make it available. And as we indicated, we will also provide answers to the question in a summary that we'll send out along with the recording of this event. And we invite you to take a look at JSI's website for additional resources and information about person-centered care. We hope you'll join us next month for our next webinar in this series, when we'll discuss accountability. Yes, we mentioned this here. Measurement, of course, our people spoke, we've already telegraphed the importance of data and workforce development for person-centered care. So we've teed this up for our next month, and we hope to see you there. Thank you once again, and see you next time. Bye.
Thank